Good day, everybody. I'm Giovanni Barbara from the University of Bologna in Italy. I'm the past president of the European Society of Neurogastroenterology and Motility and currently the chair of Gut Microbiota section of the European Society of Neurogastroenterology and Motility. And I have the pleasure tonight to introduce to you this webinar. It's part of a series of webinars that we are running. And this time, this webinar will be jointly organized with the Brazilian Núcleo Association para Estudo do Helicobacter, pylori e Microbiota. And this is an update on Clostridioides difficile infection. And I have the pleasure to co-chair these presentations together with Rodrigo, Otavio, Silveira, Silva from Brazil, Bello Horizonte. And I think that without any further hesitation, we can start this webinar. And I would like to ask the first speaker. She's an excellent speaker and very talented and expert on Clostridioides difficile. She is Professor Maria Vehreschild from Cologne, Germany, and she will talk about burden and clinical management of Clostridioides difficile infection. Maria, thank you very much for joining us tonight.
Welcome to this presentation. So I will give the first part and then I will jump in again in the end. And my first part will be on the pathogenesis, the clinical picture and diagnostics of Clostridioides difficile infection. I have some potential conflicts of interest that I want to share here, but I do not think they really do matter in my part of the presentation. So let's start with the basics. You probably already know Clostridioides difficile, previously termed Clostridium difficile, is a gram-positive spore-forming organism, and it's the main cause of infectious nosocomial diarrhea worldwide. And it's quite important to understand that it has two forms of existence, the vegetative cells and the spores, and it can switch back and forth between these two forms. That's important because it uses its spore form to infect humans, and the spores are quite resistant to acid, so they can pass through the stomach into the small bowel, and then it can change again its status into the vegetative form, and the vegetative form has flagella and it can move into the colon, and in the colon the Clostridioides difficile is then able to produce toxins, and the toxins cause the diarrhea that we then perceive as our patient's symptoms. So over the last decades, we've learned quite a lot when and how the Clostridia pass between the vegetative form and the spore form. And we have learned that biosalts play a major role in the regulation of these two forms. And here's a picture that illustrates that a bit. You can see on the left side of the picture a diverse microbiota represented by the brown images, and it's in the gut lumen. Yes, so I was saying that an intact microbiota is very important to support the transformation from primary into secondary bile acids. And these in turn are important for the inhibition of transformation from the spores into the vegetative forms and the growth of the vegetative forms, and then eventually also the toxin production. So if we have an intact microbiota and we are confronted with Clostridioides difficile, we probably end up as asymptomatic carriers. But if we are faced with antibiotic exposure and our microbiota is somehow diminished, as we can see in this picture, it's reduced in its diversity, then the microbiota is not able to transform the primary into the secondary bile salts very well anymore. And then this feedback loop is disrupted. The Clostridia can multiply and produce toxins, and then our patients become symptomatic. Then another factor that determines whether or not we become symptomatic is our immune status. And the appropriate production of immunoglobulins seems to be quite important for protecting us against the symptomatic form of Clostridioides difficile, and that is also reflected in the fact that elderly people, and especially over 65 years of age, are more likely to contract a symptomatic disease if they are exposed to the spores than younger people. So this also explains, because we have these different factors that contribute to the fact whether or not the spores will transform into the vegetative form and produce toxins. This explains why there are so many different severities of disease that we see in clinical practice. So the least severe form is the asymptomatic colonization. Then we have patients who present with watery diarrhea. In severe cases, you can also see mucus and blood in the feces. And in the very severe cases, you will have a colitis with the classical pseudomembranes on the right side in the picture. You can have a toxic megacolon with a perforation, and you can even have fatal outcomes with this disease, even though they are really not very frequent. Now, also a clinical hallmark of this disease is its recurrency. If we use the two, let's say classic but not so up-to-date drugs, vancomycin and metronidazole, then we have a 25% chance of a recurrence if we treat people with the standard regimen of 10 days. And some people develop yet another recurrence and another recurrence and may end up in a kind of cycle of recurrence where it's kind of hard to get them out again. But we will talk about this later, how to get people out of that again. And it's mostly due to a microbiota disruption that they have. But overall, to stop CDI and also multiple recurrent episodes, different aspects are important. We have to look at prevention, which would be through hand hygiene. And here it's important to recognize that you should actually wash your hand and not just use alcohol-based disinfectants. The rooms, of course, have to be cleaned well because you do want to get rid of the spores. If people are symptomatic, it's important to practice contact isolation. And from my point of view, the most important point when it comes to prevention is antimicrobial stewardship, because as you have just seen, it's important to remain to keep the microbiota intact. So the spores will not be activated into becoming vegetative toxin producing forms. Now let's have a look at the diagnostics, and here I would use a clinical case to illustrate that. We have a 62-year-old woman, and she is admitted to the hematology ward to receive an autologous stem cell transplantation for multiple myeloma. She's a bit adipose and has bilateral chronic venous insufficiency, but otherwise she has no other underlying diseases. And she now receives the chemotherapy and the stem cell infusion without any complications. Yet after 7 days, she is starting to be neutropenic and develops a fever quite rapidly. And she's starting on empiric treatment with piperacillin tazobactam. And 2 days later, she develops diarrhea with 5 unformed bowel movements per day. And here it's quite important to recognize when we actually speak of diarrhea. And diarrhea is defined as at least 3 unformed bowel movements in 24 hours. And if you want to be very specific, you can use the Bristol stool chart. and the types 5 to 7, as I marked on the left side, are defined as diarrhea. And it's important to send in only unformed bowel movements to the laboratory because we have a rather high rate of asymptomatic colonization, especially in patients who have chronic diseases or are frequently hospitalized. And what you don't want to do is to send samples to the laboratory to then diagnose a carriage. You only want samples to undergo analyses that are from symptomatic patients. But I think in this case, it's quite clear. She had 5 unformed bowel movements a day, so it's totally adequate to send in a sample to the laboratory. Now, in the laboratory, in theory, there are different tests that could be performed. The tests that are considered state of the art in the European guidelines today are colored in green here. So we have 2 highly sensitive tests. It's the glutamate dehydrogenase and the PCR test. And the first test detects a part of the membrane of Clostridia, but this test cannot distinguish between toxin-producing and non-toxin-producing Clostridia. So if you have a positive test, you don't really know if this Clostridium could actually cause disease or not. Now the PCR is a bit more specific with respect to that. It detects the gene that enables the Clostridia to produce the toxin. So it can differentiate between the non and the toxin-producing Clostridia. But what both tests cannot do is that they cannot tell whether this specific bacterium is currently producing toxin. And to answer this question, a more specific test, the toxin ELISA, is used as a confirmatory test. So this is shown in this test algorithm. Here, step 1 is that you start with one of the very sensitive tests. If they are negative, you can stop the treatment algorithm. If one of the 2 tests is positive, you should confirm it using the toxin ELISA. Then it's also quite clear if that is positive too, you can start treatment. But then there's one situation that is a bit difficult. If the sensitive test is positive, but the toxin ELISA is negative, then you obviously have a bit of a contradictory situation. And in that case, your clinical picture should guide you because the toxin ELISA test is not a very, let's say, perfect test. The toxins degrade when a sample is not analyzed for some time. So if the transport times are long, or let's say the fecal sample has been standing on the ward or in the lab for a while because it was before it was transported or analyzed, then you can get a false positive test, a false negative test, excuse me, and that will result in these discrepant results between the highly sensitive and highly specific test. And then your clinical judgment should just guide you. So if there's a discrepancy, for example, in this case, but you feel from the clinical picture is compatible with CDI, then you should treat nevertheless. So some more advice for testing. I would really not test multiple times. The tests that are recommended here are highly sensitive, and if they are negative, you can really trust them that they are negative. If you repeat them, you are more likely to produce false positive or false negative results, so don't do that. Then if you test under treatment, you may have a false negative result. So you should always try to take the samples before you start treatment that you want to base your diagnosis on. And if you do want to start empirical treatment, then you should try to collect that sample first and then start the treatment so you don't run into the problem of the false negative sample. Sorry, here I forgot to translate one sample. I wanted to say that if you are isolating the patient on the basis of CDI and diarrhea, then you should not wait for the patient to turn negative and get 3 repetitive tests. That used to be the rule in Germany some time ago, and I think also in other countries in the world. But today, isolation should really be based on the symptomatic picture of the patient. So if diarrhea has stopped for 48 hours, then the room should be cleaned and the patient can be freed from his or her isolation. So in this case, actually, there was a discrepant result. We nevertheless started treatment because the clinical picture was quite compatible with CDI. And Eduardo will now continue to talk about treatment options for CDI. And here, my short take-home messages for the first part. So the microbiota integrity and the immune status determine whether a patient will have Clostridia that will produce toxin and thus be symptomatic or an asymptomatic carrier. We only want to send unformed fecal samples to the laboratory because we don't want to detect the carriers. We really want to detect diseased patients. And ideally, your laboratory would use a 2-step algorithm that is based on a highly sensitive and a highly specific test. Now I will stop sharing and hand over to Eduardo.
Thank you so much, Maria. Well, so now I'm inviting Professor Eduardo Vilela. He's a professor here at Federal University of Minas Gerais in Belo Horizonte, Brazil. He's a preceptor in gastroenterology residence program and also the coordinator at the Alpha Institute of Gastroenterology and one of the leaders of the Brazilian Clostridium difficile group. So, Professor, feel free to share your slides. Oh, I can see it already. So feel free to view.
Thanks, Rodrigo, for this presentation. I will go to talk something about treatment and our scenery too here. What kind of hepatotypes, what kind of sequence type we have here, and how it can influentiate our conductors here in our institution too. This is my potential conflicts of interest. How common is Clostridium difficile infection here in our center? We are quaternary hospital here in Brazil, and recently we studied the density of incidence of this infection, and we can see 9.2 cases per 10,000 patients a day. It's a number greater than a multicentric study that was conducted in Europe that show 5.8 cases per 10,000 patients a day. In United States, 8.3 cases per 10,000 patients a day. And we have some peculiarity of infection here, because here in Brazil, we have isolated just 2 cases, just 2 patients with ribotype 027. But as you look at this genetic analysis, you can see that we have some sequence typing just next to ribotype 027 that here in sequence, that it's here in sequence type 1. And this kind of sequence typing, 5 of them are new ones, and they produce binary toxin too. And in another study, when we analyze how virulent can they are, you look at that in toxin production, it's not it's the ribotype 0027 produce more toxin than the mainly sequence type, main ribotype that we isolated here that cause some worry in our institution. There is it is the 883 ribotype. But when you look at these graphics in spore recounting, you can see that this ribotype produce more spore than ribotype 027 in 72 hours and 5 days. In the swimming motility, this ribotype also has some kind of more virulence aspect when comparing with ribotype 027. But when we research, when we study the antimicrobial susceptibility, there is no resistance. At least at this study, we have already studied more than 500 sequence types, 500 isolated stain here, and we have just one case, just 2 cases of resistance to metronidazole and 1 case of resistance to vancomycin. You know that how the treatment can be succeed depends, as Maria said, the produce of immunoglobulin, and of course we know that dysbiosis has main paper, can difficult the treatment too, and the infection become refractory. And this kind of sequence types here can phenotype producing something about 17% of toxin binary in our institution. It's that kind of frequency of production of binary toxin that causes big worry in our institution too. And what is the phenotype presentation of these patients here in our institution? Almost half of them are the patients had cancer. More than 75% are oncohematological patients. The median length of stay is 44 days. The fulminant infection we see in 4 patients. 60% of them were admitted in ICU, and we have 16 deaths, 3 related to CDI. The treatment response, it's about 85%, and then the necessity of the second treatment, almost 10%, recurrence 14%, and 1 patient had 2 recurrences. So how can we manage this infection here? We have to pay attention in general measures. And the first of them is infection control. You have to isolate the patient. You have to make a hygiene hand with soap. You know that soap and water is more effective than alcohol. Clostridioides difficile is resistant to alcohol. We know that. If possible, it's advisable to discontinue use of antibiotic agents and management of the electrolytes and diarrhea to correction of fluid losses and the electrolyte imbalances, give a low residue diet. And you know that loperamide and diphenolxylate atropine, it's not harmful unless when patient has ileum. So when we have a patient with ileum, it's obviously forbidden prescribe this kind of drugs. This slide represents the recommendations of European Society, and we don't have fidaxomicin here. We have already for 5 years, but now we don't how to buy. There is no commercial use of fidaxomicin in Brazil. But if you have fidaxomicin, the initial CDI is fidaxo is the first choice of treatment, and vancomycin is the second choice of treatment. If you don't have fidaxomicin, and if the patient has no severe infection, metronidazole is the drug that we can prescribe here in Brazil. In the first reference, if you have already used fidaxomicin, you can use fidaxomicin plus this kind of antibody that inhibits or make a barrier against the B toxin. And if you had used vancomycin in the first in initial CDI, you invert and you prescribe fidaxomicin for the first recurrence. And for the first recurrence here in Brazil, we have to prescribe vancomycin, taper, and pills, as we do in second recurrence too. The fecal microbial transplant, it's indicated just for since we have 3 infections, 3 CDI in the same patient. We have a particularity here when we treat high-risk patients, high-risk recurrent patients. It's advisable to use fidaxomicin, but as I said, we have to prescribe metronidazole. And in this case, we extend the treatment for 4 days or until the patient are using antibiotic. We extend the use of metronidazole if there is no intolerance in patient. We are to discuss a little more than this in the next in the follow slides, as I will show. Why fidaxomicin is the first choice when we have a commercial use, like countries in Europe and some countries in Latin America too, like Chile, like Colombia. We have here in Latin America this drug. In this study, a clinical response was the same when comparing fidaxomicin to vancomycin, but the recurrence is smaller in patients when use fidaxomicin. And you have to pay attention in this sample. 35% of patients had hepatotype 027. In this meta-analysis, it was proven too that fidaxomicin promotes 40% less recurrence or death when compared to vancomycin. So for the initial CDI is the first choice of treatment. And if you don't have fidaxomicin, as I said, you have to prescribe metronidazole. In Brazil, we don't have how to prescribe vancomycin outside hospital. Vancomycin is only commercial to hospitals and clinicals. So we have to admit patient in hospital or make a report to private issue of the patient, and the private system can support the treatment after analyzing your report. So it's not so simple to use vancomycin here in Brazil too. As we said, we for 5 years we have available fidaxomicin in Brazil, but when our regulatory agency, Anvisa, like FDA, like EMA in Europe, it's just for inpatient deliberation of the use of fidaxomicin, not for outpatient. And we don't know how they do it during this liberation, during this period of that we had this drug here. When we compare metronidazole with vancomycin, we know that response of metronidazole it's smaller, and not only this, the recurrence of metronidazole is 20% higher when compared to vancomycin. And as we said, the vancomycin is not sold in pharmacies here for outpatients in Brazil. When we have a severe infection, fidaxomicin can be used as the first choice. And in Brazil, obviously, we admit the patient in the hospital and we prescribe vancomycin in this dose. The duration of antibiotic course can be individualized depending on the response to therapy or clinical course of the patient. And we have evidence that fidaxomicin can be the first choice, even for severe CDI too, as we see in this study when fidaxomicin was compared to vancomycin with same taxes, with same rates of failure, recurrence, and mortality, and at 6 months after the treatment. Now we treat. We know that severe, complicated, or refractory severe CDI, the terminology is fulminant disease that can be present with hypotension or shock, ileus, or megacolon. In this case, you can treat with vancomycin in these doses 4 times greater, 500 milligrams 4 times a day, plus parenteral metronidazole, and you can add rectal vancomycin too at the same dose that we use by nasogastric tube. You know that there are some evidence favor to make fecal microbial transplantation in this kind of patients too. And some patients, as you see at this table that you see in this slide, some aspects, some clinical aspects can be considered to make a surgical consultation in the manager shared with a surgeon to treat these patients. As it said, it's written here: hypotension, fever, ileus, peritonitis, mental status changed, leukocytes greater than 2,000, level lactates greater to 2 millimoles per liter. Admission in ICU is an indication to make a consultation, a surgical consultation too, and all organ failure, a failure to improve after 3 to 5 days of maximal medical therapy. And about the recurrence, we know that we have something about 25% of recurrence, and when this patient have the first recurrence, the additional recurrence occurs in more than 45% of these patients. You can treat using fidaxomicin with the same posology, or you can use a tapering scheme for treat these patients until 20 days. Here in Brazil, as I said, we have to prescribe vancomycin and tapered and pills regime and use it for until 8 weeks. It's the better choice that we have here after the first recurrence. In some countries, that bezilotoxumab is available, it's of course can be a complementary treatment, as we have a reduction of recurrence, something about 10%. But by this difference, you have to treat 10 patients to have one patient to have less recurrence. As the NNT, it's about 10 by making a calculation 20% in group of that no use, compared 70% of group that use this antibody. In Brazil, we have some experience in our center with transplantation too, and there is this study showed what happens with microbiota. As you see here, there is a reduced diversity in patients with CDI, and this diversity was recovered until the day 27, then day 25, as the last observation of the patients. And you see here that we can offer a modification in a microbiota of these patients. You see here some genus, some species of Firmicutes phyllus, and these Firmicutes phyllus maintain until the 25 day. But here that appear Streptococcus more frequently. We know we can suppose that these patients are going to recover the microbiota until the CDI, until the infection by Clostridioides difficile, and had the basal microbiota after some months after treatment. We have 17 cases of transplant here in our institution, and in just one case we don't have a response. In other cases we had to do 2 transplants. In other 15 we have a good response and we treat the infection. So that's the final slide. Take home messages. Treatment begins with general principles. Vancomycin is not initial therapy except for severe or fulminant infection. Recurrence is a problem, and metronidazole can be here extended after end of antibiotic. There is no fidaxomicin here. Vancomycin taper and pills is for the first recurrence, as we said, and FMT after the third episode of infection. Thanks.
Thank you so much, Eduardo. Well, now I think it's time to call Maria back. I think she's still
some here I am.
Right, Giovanni?
Yes.
Yeah, perfect.
Maria for her second part.
Okay, so I will wrap it up a bit on the FMT. So how can we perform an FMT? There are different concepts when you do that. You can have a patient-directed donation. That means you already have somebody that you say you want to be the donor, and you use the fecal donations of that person for a specific patient. Or, and this has become more common worldwide, you have a so-called stool bank. There you have donors that are regularly tested. They are not known to the recipient, and their donations are processed, and the treatments are stored in the centralized stool bank, normally as frozen FMTs or as lyophilized FMTs, and then the recipients can contact the stool bank or the physicians to get these treatments. And then there is the option of autologous treatment, but this is really not very much implemented worldwide. So I could today, for example, make a preparation of my own feces, and if I ever get ill, I could use it to treat myself. a very nice concept, but from a regulatory perspective, a bit complex, and I think that's why it hasn't been exploited that much. Now, concerning the route of administration, there are different options. You can use the upper gastrointestinal tract by nasoenteric tubes, or a bit more state-of-the-art, you can use capsules, or you can go via the lower gastrointestinal tract using an enema, a sigmoidoscopy, or a colonoscopy. So obviously the idea behind FMT is that your microbiota is somehow depleted, and that means that the gut immune axis, the gut liver axis, the gut brain axis, all kinds of different microbiota organ axes, they are not working properly anymore because of this damaged microbiota. Now, if you replete the microbiota through the fecal microbiota transfer or transplantation, then the regulatory capacities of your microbiota are restored, and then your homeostasis is in balance again. This is a very crude description of what we think happens during an FMT. Now, how FMT got introduced into clinical practice is quite interesting, because normally when you want to register a new drug, and in many countries FMT is a drug, in others it is categorized as a transplant, a substance of human origin. But let's say you are in a country where it is a drug, you would usually have to go through many different stages to get this drug registered. But in this case, everything happened upside down, and there was really no phase 1 or 2 trial before a phase 3 trial was conducted, because the first randomized controlled trial using an FMT was conducted in the Netherlands, and the Dutch authorities and ethics committees, they judged that since FMT had been performed repetitively and over many years, especially in Scandinavian countries, it wasn't necessary to perform any phase 1 or 2 trial, and one could go directly into a phase 3 trial without any of these previous assessments. And that really gave a whole new dynamic to FMT treatment, and many other trials followed the first trial that was performed and published in 2013. And now, about 11 years later, we have a number of randomized controlled trials and large case studies. And you can see that the response rates that were reported from the first randomized controlled trial, they still hold true for most of the other studies. So after a first treatment, you usually have about 80% response in most of the approaches. And if you treat multiple times, then your response rate goes up to over or up to 90%. The only route of administration that is not as effective as the other ones is the enema. So there, after a single treatment, you can see here, you only have a 50% response. Now, there are also 2 commercial products. They are registered in the US. I actually don't know if they are registered in Brazil. They are not registered in Europe, so I doubt that anyone can buy them outside the US. One of them is Rebiota, which is actually a classical FMT that is administered via an enema. And here you can see that this is a large real-world data using this registered drug in the US. And it was just published, and you can see that the response rate is 73.8% after a single application. So that's actually better than in the case series. And so I would think if I had this treatment available, I would actually give it to my patients. And the other product that is registered is VOWST, or it was assessed in the EcoSpore 3 trials. And here the product, the SER 109 or VOWST as it is called today, was also given to multiply recurrent CDI patients. And VOWST is also very similar to a classical encapsulated FMT, except that the fecal donation is exposed to ethanol, and then all the vegetative forms in the donation die, and only the spores are transferred into the FMT capsules. So it's kind of a more focused FMT product, but it still is an FMT product. It is not a defined mix of bacteria in these capsules. So when you look at the response rates in the trial, the response rates are really very similar to a classical FMT. We again come to these 80–90% response rates that we saw in the case series for the FMTs. And we also have a comparable safety spectrum. So I would say all of these products are pretty similar with respect to efficacy and safety. So to wrap it up, FMT is a highly effective treatment in preventing another episode in patients with recurrent CDI. You can use an endoscopic or a capsule approach that is both very effective. Patients usually favor the capsule approach. FMT is also safe if all the quality controls and screenings are conducted properly in the stool bank that does it. And we have a very variable regulation between different countries, so you have to check what the situation is in your own country. And at least in the US, commercial FMTs are now becoming available, but I doubt that the people here actually have access to the commercial FMTs. Well, I personally don't. Thank you very much for your attention.
Thank you very much, Maria. And first of all, I would like to thank both of you, Maria and Eduardo, for this very nice and excellent presentations. We covered both the diagnostic, clinical, and therapeutic aspects of this common, I would say, infection. And now we have time for a few questions, not much, but a couple of questions. Maybe I can start, Rodrigo, if you don't mind. And I have a question both for Maria and one for Eduardo. So one question is for Maria regarding the tests. I'm sorry if I missed it, but I would like to know, at least in your experience, if you use both the ELISA for the toxins plus the genetic assessment of the infection, or you prefer one over the other?
Yeah, so what is established in our hospital is that they start with the GDH. If the GDH is negative, they stop the algorithm. If it is positive, they use the toxin ELISA. If that is positive, the situation is clear and they send out the result. But if the toxin ELISA is negative, they perform the PCR. So you would at least know whether you are dealing with a potentially toxin-producing C. diff strain or a non-toxin producing strain. You then still have this discrepancy where you are not sure whether this is a colonized patient with diarrhea for other reasons or an ill patient whose toxin test didn't work. So you can't get out of that, but you are a little closer to the answer.
Yeah, we do basically the same here in my hospital. So the question for Eduardo is regarding basically the presentation of the algorithm for the treatment of C. difficile, and I see that the FMT is in a rather later stage of this algorithm, but also Maria showed very nice results of fecal mitochondrial transplantation. So I wonder if in the near future the capsules become available and they are also, as we have seen, as efficient in treating the infection as the classical FMT protocol, if we might shift a little bit earlier the fecal microbial transplantation in these patients. Also to reduce, I believe, costs and recurrence. So what do you think?
Yes, I think that we are not going to wait the third episode of Faction. Could make a transplant in after the first recurrence, for example, but not after 3 episodes like we do today. I think that we shift to make this earlier, as you said.
Yeah. Rodrigo, do you have any questions?
Yeah. I think we can move forward with the question of the participants.
Rodrigo, could you tell us about our algorithm diagnosis test here? Rodrigo is he is the responsible for our lab here, and he do everything here for us: PCR, ELISA, GDA, NAT.
Yeah.
So, Rodrigo, could you tell your experience for us?
Yeah, here we have probably the biggest problem here is that we don't really have enough money to do all the algorithm. So most of the time we're trying to go with GDH first and then ELISA. And it's uncommon to have like nucleic acid tests to do after that. So we have a bunch of a lot of patients that we are like not really sure if they have CDI or not. That's probably the main problem here. And to be honest, in most hospitals, that's also a question for you, Maria, because in some hospitals, they are applying only PCR, the nucleic acid tests, as a single test. And that's quite crazy, I think, because it's interesting to see that they are reporting a lot of Clostridium difficile cases, and they are sometimes reporting they have outbreaks, and we are not really sure it's really infection because they are just using PCR as a single test alone without GDH or ELISA. So it would be interesting to hear your opinion about that.
Yeah, I also see that there is a risk of overdiagnosis. So I I would personally not recommend that strategy. I mean, that's exactly why they introduced the two-step algorithm to reduce this tendency towards overdiagnosis.
Yeah. The question here is like, okay, we have to choose just one test because we don't have enough money to do the whole algorithm. And some hospitals, they are just going to the PCR. So it's a bit hard to explain for them that that's a bit dangerous also. They're increasing the
Yeah.
use of antibiotics and everything. It's a bit messy.
But is it really cheaper to do just the PCR instead of the GDH plus the toxin ELISA? Because those tests are not that expensive, right?
Yeah. For us, it's more or less because we have also some problems here. For example, all the ELISA tests are imported. So they arrive here in Brazil with a cost that is like 16% of the 60% of the PCR. So if you have to do GDH plus ELISA, it's almost the same price for the hospital.
I see.
So in most private hospitals, they are going to this direction, and we are trying to explain for them that it's not a good idea. We're trying to study GDH, like the impact of using only GDH or only PCR, just to show them how different things are, and if you don't have enough money to go through the whole algorithm, how dangerous it is to use only the PCR. So I'm sorry, I'm just talking a lot. So I will move forward with the Fernanda Furlan question for you, Eduardo. She's asking, like, do you have experience with tigecycline for resistant infection? Is there enough evidence for its use?
Tigecycline can be used as the third antibiotic in a severe infection. We have experience here 2 or 3 cases that we have to use vancomycin, metronidazole, endovenosus, plus tigecycline. But for the first agent or for the unique therapy, there is no recommendation.
Nice. And I think
I'm
the last one is, oh, I'm sorry, Maria,
Yeah,
feel free
maybe
to.
I can add to that. In the complicated CDI situation, either metronidazole or tigecycline is recommended, and there isn't any proper data to back up any of the two, except some case series for tigecycline. But I find tigecycline subjectively works a bit better in that situation, but it's just my clinical opinion. And I also think that when we have a very strong intensive colitis, you have the risk of bacterial translocation, and then tigecycline is kind of has a nice coverage to take this into account that some gut bacteria might also translocate in that situation.
Nice. And we have a second question here. I think it's for both also. How about probiotics? That's a very common question, actually. Do you use? If yes, which one you would choose?
Maria, I'm going to learn with you.
Okay. So there actually is some good overall evidence that if you start a new antibiotic and you administer um, a probiotic with it, then you can reduce the incidence of antibiotic-associated diarrhea, including CDI. Now you can discuss which probiotic should I use. And if you look at the meta-analyses, probably it's important that lactobacillus is in it, but I wouldn't be more specific in my recommendation. I wouldn't recommend some specific product. And also a yogurt that contains lactobacillus would probably also work. So it doesn't have to be something very expensive. Um, but if you have already developed the diarrhea or you have C. diff, there really isn't any good evidence that the probiotic then still helps. Or sometimes people ask after they took antibiotics, could I restore my gut microbiota with a probiotic? And actually, some studies show that if you then use a probiotic, it actually slows down your gut restoration because the niches are occupied by the probiotic. But the diverse restoring process of the microbiome doesn't progress because everything is used up by the probiotic. So
Totally.
just wait. Don't like after the antibiotic exposure has already happened, it's better to just wait and let things,
Okay.
restore themselves.
Yeah, there's a doctor here. He says something like, "Just eat and live your life, and then your microbiota will be fine."
We are running a little bit late, but I would like to ask you maybe the last question, if there are no other question coming from the audience. Would you recommend, indications to do the tests and not over-test in the patients that are hospitalized? So basically, diarrhea in hospitalized patients is very common for many reasons. When do you suspect a C. difficile infection? So maybe elderly people, use of antibiotics, comorbidity. Some people say green feces, yellow fishes, or something like that. So when do you think we should do the test in hospitalized patients? Maria, maybe you want to start?
Okay. Well, first of all, I think it's important not to test because somebody had one unformed bowel movement, because that happens even to healthy people all the time. So I'd say the unformed bowel movements have to persist for at least 24 hours before you say, okay, let's look at this a little bit closer. And then I think if you suspect CDI, there should have been some kind of antibiotic exposure. Otherwise, it's very unlikely that it's CDI. It's not impossible, but if you do have to restrict your testing, then I would look for the antibiotic exposure in the history.
Very good. Eduardo, any addition to this?
Yes, I agree with Maria. In some cases here, I wait for 48 hours with in a patient with 3 or more bowel movements with Bristol 6 or 5, 6 or 7, like Maria said. So I wait for more 24 hours until make the tests.
Yes, I totally agree. So if there are no further comments or questions, I would like to thank our speakers for the excellent presentations. I learned so much, and thank you for the audience for staying with us. And I think that we can close in almost in time, and we will see you again for the next webinars. Thank you very much. And for us in Europe, good night, because it's quite late. For you, have a good day and enjoy the rest of the evening. Thank you very much to everybody.
Thank you. Bye-bye.
Thank you, Maria. Thank you, Giovanni, Rodrigo.
Thank you. Thank you so much.